So for this test, we want to perform it in a quiet room, 18 to 22 degrees. The patient wants to be supine on the couch. If the patient is sat up or supine on the couch, it can void the results. So the patient needs to be supine. They want to be relaxed for at least 10 minutes. Okay, so the patient wants to chill out on the couch, explain the test to the patient, gain consent, and then we can use that time to put the cuff on the patient's arm. We also want to have all of our tools available to us. So we've got our SFIG cuff, we've got the gauge, we've got the Doppler, definitely have some towels so you can wipe away the gel, and then we've got the gel itself. So have all of these things to hand. You want to make sure that the gauge on the is zeroed and that it's calibrated on a regular basis. The general approach would be we want to try and have the best flow that we possibly can. So we want to start with the left arm, the left brachial pulse first of all, and then we want to move down to the left foot, do the posterior tibialis, then the dorsalis pedis, and then we would repeat on the right foot and then finish on the right arm. So as much as you can, we want to have a flow where we're starting from one side of the body and finishing around on the other. Okay, so we have the SFIG cuff attached to the gauge. Mark is to the far end of the couch, so it gives us a bit more space in order to use our equipment, have a bit of freedom. With the cuff itself, they're often a little bit different, but they usually have a little marking on which needs to be approximately over the artery that we're looking to compress. So in this case, the brachial artery, so the marking wants to be on the medial aspect of the elbow. So you can see this here is in a reasonably good position. With the gauge itself, if we turn this gauge on to the side, it's fully turned to the right. And what that means is that when we inflate the cuff, the air is going to be trapped. Okay, so that's the position that we want it in when we perform the test. So we're going to use our hand here. It's a little bit tricky, but you're going to use your fingers. When we release the pressure, we're going to be moving that up slowly to release the pressure. So you really need to get used to that kind of two functioned position with the hand and the fingers. Okay, it can be a little bit tricky. So that's that. With the probe itself, obviously we're going to have it turned on. Again, it probably does matter how you hold the probe. So in this case, it's probably easier to have the wire on the outside of the arm and have it on this kind of little space on the couch. So you can have it on the inside or the outside, personal preference, you can swap hands, but for me this feels most comfortable. So we would have palpated the pulse, we would have dropped a little bit of the ultrasound gel onto the medial aspect of the elbow. With the probe itself, we want to be approaching it at about 45 degrees. So we're not going to be directly over the pulse that we're looking to find. We're going to be at a slight angle, about 45 to 60 degrees to the skin. Okay, and it wants to be light pressure initially. Don't push really hard because that may compress the vessel. Okay. So with the actual test, what we do is we locate the pulse, so the brachial pulse, the hand rested onto the forearm so we can keep that hand nice and steady. What we do is we would then pump up the gauge until we lose the pulse that we can hear on the probe. Okay. Once we've lost the pulse on the probe, we want to then go about 20 or 30 pressure on the dial higher than the point in which the pulse disappears. At this point, what you would do is you'd then slowly release the gauge, so we'd move it left a little bit, and the gauge will slowly come down, and the point in which we get a consistent return of the pulse is the number that we want to record. Okay. A couple of things on that. You might hear a little bit of turbulence, a bit of a whoosh coming through before the pulse comes back in, the systolic brachial pulse. That's not what we want. We want a consistent pulse returning. The swoosh is turbulence, and that kind of indicates that the pulse is about to come back. But that's not where we would clock the pressure. The other thing I would say is it wants to be a consistent pulse. So if you're getting just an occasional noise, but then it goes away and then we get a consistent pulse, we need to be mindful that that was probably an abnormality. So we do it nice and slowly. We go 20 to 30 pressure above the point in which it disappears, and then we would turn it left, slowly release the pressure, listen in for that pulse coming back. We would then document that pulse, and that will then be the brachial systolic. That's the number that we want. We would then take all the pressure out, wait about 30 seconds, and then we probably want to do it at least one more time. And that is in order to be consistent, that we can be reliable to ourselves, and that we are sure of the result that we've got. Right, okay, let's perform the tests. So we've located the pulse, nice and strong, triphasic, and slowly start pumping up. So we've lost it at that point. Slowly ease it off. So that was about 105 there. We'll let that come out. We would ordinarily wait another 30 seconds. Make sure that we've got a good pulse coming through. That's fantastic. Close the valve again, and then we'll repeat again. $105. Okay, so 105, make sure we document that test. This is where we're going to come in and just wipe that off his arm. So that's the left brachial systolic pressure done. Okay, so we're now down at the ankle. So we've done the brachial test first, and then we're staying on the same side, and we're coming down to the foot to do the pedal pulses. So the pedal pulses are the posterior tibialis, which is kind of halfway between the medial malleolus and the Achilles tendon, so around about here. And then we've got the dorsalis pedis, which is kind of just a bit further down from the ankle. There is a little bit of variation with different people in terms of where the dorsalis pedis, which is an extension of the anterior tibialis tendon, is located. So you do kind of need to palpate that first and kind of have an idea of where you're going to put your ultrasound gel. So it's about here, which the textbooks would usually say that it's online with the web space of the big toe and the second toe in. But with Mark's, it's a little bit more central. So just kind of be mindful of that. The cuff itself, the bladder in this particular case wants to be facing up to the knee. Now the reason for that is to just remove the bladder as a potential obstruction around the foot. And there are no rules to say we can't do it that way. The main thing is that the cuff itself is reasonably snug around the ankle. It wants to sit just above the medial and lateral malleolus. So I can feel them there. It just wants to be just above that level. So we've got that little mark, and it wants to probably be, it's not needing to be over each individual artery, so don't worry about moving it around. Just have it approximately in line with the ridge of the tibia. So here it is here. That is absolutely fine. So the bladder connector is facing up to the knee, and then we're approximately mid-shin with that arrow, and then tuck that underneath, and then make sure that we are above the medial and lateral malleoli. So that's the cuff. With the Doppler, have it in between the feet. Okay, so you've got plenty of space to kind of maneuver, just kind of move this leg out a little bit. And obviously we're going to be coming in and doing the posterior tibialis first here, and then we will be moving round to the dorsalis pedis. So it might mean that you need to change hands, and it's perfectly okay to change hands if you feel more comfortable putting your probe in the right hand, even though you'd used it in the left hand. So you need to be a little bit ambidextrous, and you need to decide prior to doing each test where you're going to place everything and have everything to hand. So we've located the pulse. It's not as strong as the one in his left arm, but it's reasonable. The valve is closed, and then we're going to pump that up until we lose it, and then a little bit more. $130. Let that release fully. Close the valve again. So we've closed the valve, we've waited 30 seconds, and we're going to do it one more time. Just a little bit more, and then we're going to release that slowly. Okay. 132, I would say. If you're unsure, you could do it a third time. Between 130 and 132, so we'll probably say 132 with that test. Okay, so we've located his dorsalis pedis. I've changed hands. We've closed the valve, and then we're going to (20, 30 degrees). Let that come out gradually. $130. Let that go back to 0. Close the valve. You okay there, Mark?
Yep.
And I'm going to repeat that again. So we know it's at least 130. Okay, maybe 128 with that one. And let that one release back to 0. Right, okay, so we've done the left brachial pressure, the systolic pressure, which was around 104, 105. We've also done the left posterior tibialis, which was about 132. And then we've done the left dorsalis pedis, which was 128. Okay, we would then move to the right foot, do the posterior tibialis, and then the dorsalis pedis, and then we would finish with the right arm. The reason for that is it's just making your workflow a little bit easier, so you don't have to be constantly moving left and right, and make that flow a little bit easier, a little bit more comfortable for your patient. So, so we would do the left side, we'd do the right side, so we'd have a left ABPI and we'd have a right ABPI. So if we look at Mark's left side, so it would be the left highest of the left pedal pulses, which was the posterior tibialis at 132. We divide it by the highest of the two of the arms. So for argument's sake, let's say it was 104 with the left. So in this case, his ankle brachial pressure index would be 1.2, okay, which is well within a normal range. So we'd want to know what his ABPI is for his left, which is the highest of the two pedals divided by the highest of either the right or the left arm. And then we'd want to know his right ABPI, which is the highest of the pedals, divided again by the same value in the arm, in the brachial pulse. And so we want to do it on both legs.